Thank you so much, and thank you, Dr. Shaukat, Dr. Bansi, and the whole organizing committee for inviting me here. Although you see that I don't look like a Norwegian. I don't have blonde hair. I'm originally from Bangladesh. I'm very much part of this Indian history, and so I feel very much at home. Thank you for inviting me to my home. So the topic that I'll be talking about is the diagnostic challenges. We see that this is a kind of vital issue because yesterday my good friend Professor Lenongji, he demonstrated that who is labeled wrongly. And this is a kind of serious concern for us, for the doctors, to look at. I will not spend more time because we have discussed these things that diabetes is increasing. But why diabetes is increasing? It's a number of factors, and one of the factors which we never discuss is actually diagnosis. And because we are changing the diagnosis every time, and we don't discuss that what it is effect for the increased number of people labeled as diabetics. As this is again, China and India is again competing in terms of the number of people with diabetes. And as you see that Bangladesh is one of the top 10 countries already, and it is now as number 8, and which is going to be number 5 in 2030. In simple terms, if we think that what is actually diabetes, it's a state of chronic hyperglycemia, whether it's due to lack of insulin or defect in insulin action or both, that can be discussed. So it's what we are discussing, the way that we are discussing is actually hyperglycemia. The state of I'm not getting into the discussion that whether it's a disease or it's a condition. So if we look at this etiopathophysiciology of diagnosis, we see that this is the blood glucose level that it raises, and this is the normal, impaired glucose, and the diabetes. And if you see this insulin level, so this is one of the things that when we are seeing that this number, where is the point? Okay, you see that when it is increasing, the insulin is increasing much faster. So at this stage, we are not able to diagnose. We can say this is impaired glucose, but you see that at this normal level, the insulin level has started increasing, which we are not able to identify for early diagnosis. We can also see that this is a pro-insulin secretion. We can also look at this insulin resistance. Will actually start. Already you see that insulin resistance starts actually from what we call normal state. And this is one of our challenges, that how do we diagnose it so that we can for the early diagnosis and not mislabeling them. And it's also free fatty acids. And at this stage that we have, so that debate, for example, we have seen that Professor Mohan yesterday, he has discussed that whether we should start early insulin therapy at the point of diagnosis. One of the main argument for his argument is that we don't diagnose this at this point of time. We generally diagnose this at a later stage where we already see A1C level at a higher level, and probably in some cases we already see the complication. Complication is already there. So if you're going back to this diagnosis, we see that we have 1980s and 1985, 1997. We have changed 3 times. And we have changed from fasting from 8 to 7.8, and then we are coming down to 7.0. So this classification in 1997 is based on the so-called etiopathophysiciological state, and that means that we are saying that we are using insulin for example, for type 1, it's actually for diabetes, for survival, whereas for type 2 is actually for control. But if we look at carefully the agreement between the way that we are diagnosing the fasting and the oral glucose tolerance test, the agreement between these two is very poor. It's 28.4%. And that causes us the discussion that we as physicians, we should be discussing that when we are doing it either by the fasting or by the OGTT, where the agreement is only 28%, what is the risk for the false positive cases that we are including? Because when you are labeling, when you are diagnosing with somebody with diabetes, they have a kind of severe consequences for their life. And we have also published some data from Bangladesh, and we have also shown that actually in Bangladesh we see that it was round about 40%, the agreement, that it varied between 30 to 60% in different studies. We have also looked at this, for example, variability, that we have seen that we have seen the fasting plasma glucose on two different levels, and we see the agreement with OGTTs. You see that it's not kind of uniform. There is a kind of quite spread. We see more agreement at a lower level of fasting blood glucose, and at a higher level we see a kind of more spread, whereas OGTT level we see more probably agreement at a higher level, at quite a higher level, but otherwise it's quite spread. And that puts the question that the person that is being diagnosed with diabetes today, what is the likelihood that this person will be diagnosed or not diagnosed in the next day? So based on this, that we have this major, you can say that we have this major, the ADA, the WHO, that is what we have at the moment, and the international group that came up with this A1C level, that is, we are agreeing to 6.5%, and this is, they are saying that the main reason for this, because A1C will not have this day-to-day variability, which I have just shown. This clinical dilemma actually starts with the poor agreement between fasting plasma glucose and OGTT, and the risk of increased fasting plasma glucose, false positives and false negative cases. And previously, Rubber and colleagues, they have already, in 1968, they have already discussed of glycated hemoglobin. So the debate of the glycated hemoglobin is nothing new. So what we have agreed, this world we have agreed in 2007. This is the consensus, world consensus on the statement published. That is, recommendation from the International Expert Committee is that A1C is an accurate and precise measurement of the chronic glycemic levels and correlates well with the risk of diabetes complications. And also diabetes should be diagnosed when this is the cutoff level of 6.5%. And then we are also saying that if possible, this testing is not possible, then previous recommendation, that means the way the WHO's recommendation should be followed. And if A1C is tested, is indicated in children in whom diabetes is suspected, but the classical symptoms of casual plasma glucose of 200 or 11.1 are not found. So if we say that, that means that we are saying that the diagnosis should be starting at 6.5, and the glucose control also should be maintained at 6.5%. And this is the recommendation, and the United and diagnosis guidelines that was developed, and it is Diabetes Care, which is published in 2009. It says either by the fasting plasma glucose, or by hyperglycemia or this glucose load, or 2 hours plasma glucose, and which came in 2010 as any of these, A1C more than 6.5%, or fasting plasma glucose, or 2 hours plasma glucose in patients with glycemic symptoms. And we have already seen that Professor Lenongji has stated that by adding this to glycated hemoglobin as or, that this prevalence rate increased by 2%. And whether they are true cases or they are mislabeled. So this is something that we need to see. And the clinical utility, as we said, that red blood cells span is about 120 days, is 4 months, so it gives a kind of average, it gives a kind of estimation of not only 1 day, but of 4 months, and therefore it is more stable and is more recommended. But if you look at the hemoglobin, A1C, what we said, it is a non-enzymatic glycation that occurs, and it actually is the glucose and hemoglobin that we have here, and that comes, this bond comes as a hemoglobin, that is this percentage of A1C in hemoglobin given as percentages within the span of red blood cells, that is over 4 months. That's what we are measuring. So if we have, as we said, that in Indian population or in our population where we know that, for example, anemia is quite common, then the effect of it is likely to be higher because the percentages of the hemoglobin would be less. And A1C test reports amount about a proportion of it, and we have lots of publications showing the importance of A1C. That we have seen that there is microvascular complication, macrovascular completion, any diabetic-related endpoints, or diabetes-related deaths. And we also have retinopathy, nephropathy, neuropathy, and microalbuminuria given only 1% changes in A1C level. So we have shown the beneficial effect of good control for A1C. But if we look at the diabetes management guidelines globally, that we see that there is quite a difference. As for example, Canadians, they are using 7%. We are using UK in some areas that's 6.5%. So there is ADA is 7%. So you see Australia is 7%. So it's not uniform. It's quite divided when you are talking about diabetes management goals. We have done this study in Bangladesh, and we have looked at the sensitivity and specificity by A1C for the given diagnostic criteria. And we looked at and we found out that actually for the Bangladeshi population, the better, highest sensitivity and specificity we are finding at actually 6%, not as 6.5%. This is the best sensitivity that we are finding with 6%, which we have already published in Diabetic Medicine. And this is also the study from China, and they are also showing that, for example, the best sensitivity and specificity they are finding in 6%. So in the Asian population, that what we are finding is not 6.5%, actually is 6%. And we have also constantly shown by Yasnik and his group the level of anemia in this population and how this is affecting the estimation of glycated hemoglobin. So this controversy is imperfect concordance between A1C and fasting plasma glucose and 2-hour plasma glucose. And A1C cutoff of 6.5 identified one-third of the fewer cases. You see that this was the initial idea, when they said that HbA1c should be the diagnostic criteria. They said that they will be diagnosing one-third of the cases of diagnostic diabetes, and therefore we made compromises by saying either by fasting or by OGTT or by A1C, and that which means that we are increasing the risk for mislabeling. And A1C detected fewer diabetics than OGTT in both cases in these studies, and therefore the patients' level with A1C and fasting glucose were 32 times more likely to progress to diabetes than those with one test alone. So that means that one test sensitivity is still quite low. So how do we move forward? Forwarding the Diabetes Care Journal now requires both units as percentages and national and this micromoles units. That is the International Federation of Chemistry that came. And they say that in that way, that probably it will be easier for us to understand and harmonize these different ways of measuring. And why now? There's standardization, this NGSP, this reference HPLC is included in DCCT, which is the British one, did not use pure HbA1c. So that was the problem, that when the British recommendation that came, they haven't used a pure HbA1c, and I will show you the results. And the IFCC units, shows that it's about 1.5 to 2% lower than the DCCT values, and therefore we need a calibration and we need a standardization. So why changes from DCCT? Because if you look at the DCCT changes, this was the original DCCT method, and because they haven't used the original hemoglobin, and therefore there is an interferences of 1.6%. So if you control for this one, the new methods, that it is saying that then they will not include this 1.6% through the IFCC methods, it will only take this 6.4%, and therefore they recommended not the DCCT methods, but the new IFCC method. And Scientists and clinicians have agreed that it is no longer tenable to report results which they know would be falsely elevated. So therefore, they are now discarding the DCCT levels. And then the problem is the inconsistent units, that you see that as IFCC units as micromoles, and the current HbA1c reporting percentages is two different units, and therefore it causes confusion. And there is a relation, but we find a linear relationship between A1C and glucose methods established by, which was shown by Nathan, Nathan and in Diabetes Care in 2008. So if you look at the brief history of standardization, what has happened in this process of standardization is DCCT method, it actually came in 1987, and that was, we have shown that it is falsely elevated. And this ASC, the American Association for Clinical Chemistry, they came up with the 1993. And NGSP, it came, the National Glycohemoglobin Standardization Program came in 1997. And IFCC came in 1995. So this is the more or less kind of brief history to unify these disagreements. And how we switching over to IFCC units. The American Diabetic Association and the European Association for the Study of Diabetes and International Diabetes Federation have agreed that A1C is to be reported following the International Federation. So we said that no longer is percentages, we should be using the IFCC methods. IFCC reporting was introduced in Europe, except for UK. UK didn't accept it until 2003. And now they are saying that they will give a kind of dual reporting of both their DCCT method and IFCC method. And this conversion is an equation that how do we convert, but as I know that the doctors are poor in mathematics, so I'm showing you some simple ways. That this was the DCCT methods that was 8.8%, and we saw that there was about 1.4%, which was falsely elevated. So with the IFCC method, it is about 6.4%. And 8% of A1C would come to about 64 micromoles in terms of the IFCC methods. And there is a kind of relationship, if you look at these relationships, IFCC methods and DCCT values, so there is a linear relationship. So it's not, if you think of the risk predictions, actually it's quite stable. And this is the way that we can switch from IFCC units from DCC methods to the IFCC methods. But for simplicity's sake, I'll show you that if you have, for example, 7%, that you can deduct 2 and 2. For example, if you deduct 7 minus 2 is 5, and 5 minus 2 is 3. So it will be 53. So you see that 7 minus 2 is 5, and 5 minus 2 is 3, is 7% means 53 ml. So actually this is one way of deducting 2 plus 2. But another problem rises when we are looking at the A1C, that you see that even though we are saying that it has 4 months time, but you see that there is variation, because, for example, that if we are taking a month from May, that means we are taking of February, March, April, and May. And we see that, for example, the first month, because of this continuation of glycation, the month of February would actually represent only 6.5% in the A1C assay. March would probably give you 14.5%, and in April it will give you 27% in May. So the majority that we are looking at is actually last month actually we are doing the test. And that gives rise to the question that whether we can have an estimated average glucose instead of this A1C in that sense. So there is a consensus statement that is coming that estimated average glucose results were not included in the consensus due to the mentioned limitations. However, the use of EAG in discussion with individual patients may add to the consultation process, because then this estimated average would tell more of the way that the patients are estimating their blood glucose. as is in micromoles or whatever the measures, units they are using. So it's now agreed that we should give this, so ADA, we should give the estimates in presentation with, as you say, the DCCT methods, IFCC methods, plus estimated average blood glucose, which would be, I think, which is quite confusing for the practitioners and also for the patients. But estimated average glucose is probably would give you the advantage of, for example, for the same units, confidence in the meaning of the A1C, because then people will probably better understand the meaning of the A1C, particularly the patients. But what is the relationship? And the relationship, we have seen that the relationship is also, as we have seen previously, that actually it is highly correlated. But what are the challenges in A1C assessment? The hemoglobin type is inherited or acquired. And we know that there are about more than 700 forms of hemoglobinopathy or abnormal hemoglobin variants that have been reported so far. And because the A1C test is based on normal hemoglobin, hemoglobinopathies can affect the reliability in the test in 3 different ways. That is altering the normal process of glycation and causing the abnormal peaks in chromatography and making the red blood cells more prone to hemolysis. And all these factors we have to take into consideration when we are going for A1C. A1C is not an option for everyone, and this is also WHO pointed out that limited availability and standardization testing facilities and higher cost may pose a barrier to the adoption, because we know that it costs more. The American Endocrine Society said that more studies need to be done in population other than those of the European ancestry. And this is really limited, as we have seen that we have done a study in Bangladesh which seems to differ. The Chinese study is also seems to differ. And therefore, it comes to the question that whether we should have an ethnic-based diagnostic criteria. The summary. With this summary, we can say that HbA1c for diagnosis offers greater convenience and accuracy than glucose measurements and correlates well with the long-term complications. Introduction of metrologically sound measurements, which is coming with the IFCC units which I have shown, for the conversion of the A1C values is an important step. And clinicians are more interested in the average blood glucose. So therefore, we should think the estimated average blood glucose with 95 confidence interval is probably would be more interesting and more meaningful. We need to overcome the potential limitations of A1C measures for the conditions like hemoglobinopathy, which I have just shown. Most importantly, I think that it is conceivable that the physiology of glycation may differ by ethnicity, and therefore further studies need to be needed for the standardization of A1C in the populations like Asians, Pacific Islanders, Africans, and in their own setup. And most importantly, that what we have seen that all these diagnoses until now, these are based on cross-sectional studies. The limitations that we have found that when we are trying to analyze our data, because what we are measuring, the sensitivity and the specificity we are measuring with the standard diagnostic procedure. And if we are measuring with the standard diagnostic procedure as the gold standard, then how can we say that A1C is better? Because the sensitivity could be 80%, could be 90%, but not more than 100% compared to the standard ones. So we need to do the follow-up study in a cohort study in order to establish the diagnostic criteria that we have used in order for the risk of diabetes. Otherwise, there is a risk that we are mislabeling number of patients, and which is a concern, ethical responsibility for the physicians. Thank you.